Dream sequence. I can't remember if we even liked each other anyways. I guess it's coming back, the kissing the holding hands, those were the days. Now I'm thinking about the way things were before. Thinking about the days we lost to love. What you know, 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 what you know about that? What you know about that? What you know, 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 what you know about that? What you know about that? Hard to believe, but you love me, I love you too. How far we've come since then. Too late to mend the wounds. You know I speak the truth. It's time to go our own ways. Now I'm thinking about the way things were before. Thinking about the days we lost to love. Oh, now I'm thinking about the way things were before. Oh, now I'm thinking about the days we lost to love. What you know, 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 what you know about that? What you know about that? What you know, 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 what you know about that? What you know about that? Now I'm thinking about the way things were before. Thinking about the days we lost to love. Now I'm thinking about the way things were before. Thinking about the days we lost to love.
Como vai este ritmo bueno y sabroso al descanso de bem, 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 que mira. Como vai este ritmo bueno y sabroso al descanso de bem, 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 que mira. Como vai este ritmo bueno y sabroso al descanso de bem, 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 que mira. Como vai este ritmo bueno y sabroso al descanso de bem, 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 bem. canta de ven, 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 que mira cómo va este ritmo bueno y sabrosón. A las canta de ven, 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 vámonos, vámonos, mamá, va, vámonos, vámonos, mamá, va, vámonos, vámonos, mamá, va, vámonos, vámonos, mamá, va, vámonos. Vámonos, mamá, va, vámonos, 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 vámonos, mamá, va, vámonos. Vámonos, mamá, para que goten los pollitos. Ven, 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 ariquiqui, ven, 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 ariquiqui, 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 yeah. Ariquiqui, ne, 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 yeah. Sabor. Oye, cosita linda. Te traigo la zucchini. Vámonos, vámonos, mamá, va, 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 vámonos, vámonos, mamá, va. Que mira, esa mulata, esa tierra no se muere.
Every day I feel like I got you folded up inside my top body.
Naples, founded in December.
Celebrate when I can't remember. Hold on to all of what we had. It was you in the photograph. I don't need to lie. Anybody else, they would never do. You're the only one who smiles. It was you in the photograph. I don't need to lie. Anybody else, they would never do. You're the only one who smiles. Take away instead of eating out tonight. Lighting up a candle just for fun. But I know just what you want from me when I don't even know myself. How could I get this far and never see? Maybe love is asking for some help. I'm crying, oh, let's take it slow. And maybe we can just dance tonight, yeah. I'm crying, oh, it takes time to grow. This world has got me twisted up, chasing love, can't stop till I can feel you. We can sip that rooftop champagne all night under the full moon. And yesterday will float away. I can say there's so much more than illusion. This world has got me twisted up, chasing love, can't stop till I can feel you. Presenting Sicily for love. Just take me closer.
Just take me closer.
Just take me closer.
Just pull me closer. And if you wanna, just pull me closer. And if you wanna, just take me closer. And move. And if you wanna move, just pull me close to you. And if you wanna, and if you wanna move, and if you wanna give me a feeling. And if you wanna move with me, baby, and if you wanna, and if you wanna move with me, baby, move with me, baby.
Okay, I think we're ready to start for the next session. It's been an interesting morning so far, and I think it's going to follow in that theme. The next presentation is from David O'Kelly and his colleague David Walsh, both from KPMG. And they're really going to give us a look at with the investor lens on at the Irish healthcare landscape right now. It's been an interesting time in the investment landscape and a challenging time, as many people know, and they're going to give us their assessment of it. David is the head of M&A at KPMG, advises CEOs, CFOs and board levels executives on developing and implementing their strategies to maximize value. And he's done a lot of transactions, including, I must declare, he supported me on investment funding, and I must say he's a consummate professional and has great personal values and integrity, and was fantastic to work with. And he's joined by his colleague David Walsh, who leads their healthcare strategy on the transaction services side. And David is actually a pharmacist by background and has really worked a lot, both in Ireland and internationally, in defining, validating and articulating strategic ambitions, as well as undertaking commercial due diligence. So I call on the two Davids. Do you have to be David to be on your team? Yeah. And to take us through that. Thank you.
Thank you, everybody. Hope you enjoyed your coffee. I've worked with Tom before. We've known each other a long time, and delighted to get the invite to speak here with you today. So when Tom and I were talking about this, we're talking about, look, maybe I'm a private sector guy. I'm a partner in KPMG. I lead the M&A practice. I have some redeeming features. I sit on the board of the Matter. I've been on the board for the Matter Public, been on the board for Matter Public for 6 years. So I'd never tried to claim to be kind of very much of the industry, but of a good ringside seat. I do think I've learned an awful lot over the years. So talking to Tom about this session, we said, look, it would be good to get the investor lens. When you look at healthcare is predominantly a public business, but the private provision of healthcare is a really, really important part of it. So I invited my good colleague David Walsh along. David, as Tom said, started out as a proper healthcare person, as a pharmacist. Spent 8 years as a regulator, and thankfully has joined our team now and leads on some of the most complex strategic advisory assignments we get in the healthcare space in Ireland. And what we're going to do is give you effectively the investment rationale, how we see that there, what the investment case for healthcare is in Ireland. We're going to take stock of the investments have been made, the transactions that have occurred in the space, and then maybe from some of our conversations that we have with investors and colleagues. KPMG is obviously a global firm, so we've touched base over the last couple of weeks with colleagues all over the world to get some input in terms of, like, what are the investor priorities, what are they seeing, and how does investment work when it works well. So at that, I should say, Tom, we did have some diversity. We had, my colleague here, Siobhan Dunleavy, was due to speak here as well. She regrettably lost her voice. She recovered it, so we could get back up. She lost her voice, so isn't able to join us on stage today. But we were going to have both name and gender diversity on the stage, which I thought would have been better. So at that, I'll hand over to David Walsh.
Thank you very much, David, and good morning, everyone. So I'm going to take about 5 minutes of your time just to, I suppose, set the scene from an investor perspective in terms of what they might be looking at when they're thinking about investing in the Irish market. We've heard quite a bit today about demographic trends, so I want to unpick that a small bit more. And somebody made a reference earlier to data. I'd like to dig into it a bit and give you some of those facts and figures. So currently, Ireland is one of the youngest EU countries, but we are aging at the most rapid rate. So over the previous decade, the median age in Ireland has increased by about 4 years, currently sits at around 39 years of age. We've heard a bit about the over 65s cohort and how much demand, I suppose, that is going to come from this cohort over the next 10-year period. But to contextualize that a bit for you, by 2034, so in 10 years from now, that cohort will represent around 18.5% of the population. And what that means in practicality is an additional 250,000 individuals will have additional healthcare needs across the country. Where will these people be based? Well, it's important to consider geographics. So the reality is the entire country is aging. But in 10 years' time, The oldest regions, so the parts of the country that will have the greatest population of over 65s, will be the border region, so it's area number 1 on the map behind me, the west of Ireland, so in and around Galway, so area number 2, and the Midwest, so area number 6. Alongside an ageing and growing population, Ireland has a significant number of people on national public waiting lists. So currently, this is at over, or thereabouts, 700,000 individuals currently waiting care. And these figures have been over the 600,000 mark since 2018. So again, indicating the excessive demand that exists within that public system. We see this demand geographically distributed across the country, but again, you see concentrations of it in the hubs that we all know, Dublin, Cork, and Galway regions. And to meet this demand, we see increased expenditure by the HSE, and this was alluded to earlier today, over 23 billion in 2022, and this has grown annually at a rate of 13% since 2019. This expenditure is occurring across all segments, so everything from acute hospital services, primary care, disability, and older persons care. And this is very much a trend that we expect will continue. As a result of the capacity issues that exist within the system, increasingly what we're finding in the businesses that we're dealing with is individuals are prioritizing access to healthcare, and they're doing this through the private system. We heard a speaker earlier today from VHI, and I'd like to talk a small bit about the private health insurance market in Ireland, as it's a key indicator, I suppose, of private activity as we see it. So there's around 2.4 million people in Ireland who currently hold private health insurance, around 47% of the population, thereabouts. Market penetration of EHI varies geographically. So in the Dublin region, it's around 63% of individuals have it. It drops off slightly in Munster, falls down to around 51%, drops off lower again in the Connacht and Ulster region, in and around the 30% mark. As I'm sure most of you know, VHI has by far the largest market share, currently at 48% of the market. But dynamics are slightly shifting. So both Leia and Irish Life have captured market share over the previous decade, and they're doing this with a younger member base. And this is very much a trend that we expect will continue. Our research into this particular market tells us two key things that I think might be important for this room. The first is that private health insurance members value access to private procedures in private hospitals. That is one of the key things that they look for when they're choosing a plan. And the second, and it's somewhat contrary to what we see in the news, is that despite recent price increases, private health insurance is still viewed as good value for money. So what does that tell us? It tells us that the market is unlikely to contract anytime soon. Last piece from me, we've talked a bit about public expenditure, but looking at the expenditure from the private health insurers themselves and what they're actually paying out in terms of claims. So the payouts have increased between 2012 up to recently at around a 4% rate per year. But the highest growth is in that other claims segment, and this includes primarily primary care. And this makes sense when you think about it. We see increasing incidental care clinics across all providers across the country. And again, this is something that we expect will continue as we shift more towards that payer-provider type model. So I suppose to wrap from my side, a couple of key takeaways I think are important for any investor to know about the Irish healthcare landscape. Number one, demographics are driving demand, and they'll continue to drive demand for healthcare services through to the next decade. Number two, waiting lists are increasingly pushing individuals to seek care in the private sector. And number three, both public and private players are increasingly deploying capital to meet this demand. And this is something that we think is going to continue. So with that, I'll pass back to the other David to bring us through some of the M&A activity. Thank you.
Really, one of us should have changed our name for the day. So in terms of the transactions, where money has been going, 160 transactions in Ireland in healthcare since 2018. That's quite a number of transactions, one of the most active sectors for M&A in Ireland. What's really, really interesting is that 75% of the transactions have been nursing homes. That's just a staggering portion of the level of investment. Now, this chart here is by volume. If you changed it to value, clearly some of the large hospital transactions would skew the value more in favour of those types of deals. And 14% of the deals are in primary care. I'd say people probably don't realise quite how much just generally has been going on in primary care, and I have a nice graph on that later on too. So it's been quite an active sector. What's very, very interesting is that it got very active during COVID. So 2021 there, you see the peak level of transactions. There's probably a couple of things driving that. One was, quite frankly, COVID was a really difficult time, as we all know, in the healthcare sector. And did we end up with more willing sellers who are saying, look, they just can't see themselves doing this for another 5 or 10 years? And the other factor was that valuations were very strong. Because what we saw were property-related businesses, a spike in value driven by property funds who are willing to part acquire those businesses. Since 2022, those valuations have been more difficult with rising interest rates and some other factors. So we've seen a focus, as we talk to investors, much more interest in asset-light businesses. So less interest in building, or acquiring large portfolios of nursing homes or building big hospitals and so on. Much more in asset-light businesses that are providing, care either in the community or are providing care ultimately through people. In terms of the types of buyers, so half the deals have been trade buyers, so that's one company buying another company and expanding and improving the range of services and the quality of services and so on. Property funds, noting that trend, so that they account for about 38% of transactions. The private equity or infrastructure fund number at 11%, that kind of surprised me, to be honest, when we pull this data together. To make it, we do. There is a frequent debate about the role of private equity in healthcare and the time periods that they might want to seek a return versus ultimately the responsibility and all the effect that the governance that we had in the governance discussion we had in the last session. But 11% relative to other sectors, private equity generally in 2023 equated to about 30% of transactions. So 11% is very much underweight. And talking to our head of M&A in the States, he'd say that 30% in the States is more like 50%. So there's probably a couple of things we can take from that. One is that we're underweight, and then the other is that we can probably expect that to increase over time. There's a vast amount of money sitting in private equity untapped. The last time I saw the number, it was something like 2.1 trillion of cash sitting in private equity fund waiting to be deployed. And there's, the model of deployment, for the vast majority of private equity investors, if you invest in a business, you got to leave it better than when you bought it. Otherwise, the model doesn't work. People who are investing in healthcare businesses want to see that they're good businesses that take care ultimately of the patients. So talking to my colleagues through my counterparts through Europe and investors and so on, like what's their take on Ireland? David has very professionally covered off the demographic fundamentals. So in two hands, you say, look, that is a massive public sector challenge. As a country, we have a moral commitment to take care of people who need care, and I see that directly in the matter where I'm involved. But that's also a private sector opportunity. There's huge ability for the private sector to tackle things like waiting lists and provide care that can complement the public system. The relatively high level of health insurance penetration, so touching 50%, that is far higher than we've seen in the UK and many other European marketplaces. And that's a good thing. It effectively provides additional funding that can help people start private healthcare businesses and also take some level of pressure off the public purse. Unfortunately, it's pretty clear from the waiting list data that we saw that there's a capacity deficit. We all know this. There is a deficit of capacity, and based on that demographic information, it's going to get worse. So we need to figure out more ways to bring more capacity into the system, whether that's through more capital or better getting more out of the facilities that we have. The fourth point here may even surprise people in HICWA, that investors overseas take a lot of comfort from the strength of our governance systems, from the strength of HICWA as a regulator. Now, HICWA's job isn't to provide comfort to investors. HICWA's job is to inspect healthcare operators and provide comfort to the system and to patients and their families and so on. But the fact that they do such a good job at it sets Ireland apart from some other countries. And that's a real plus in terms of attracting capital into the market. People who are being audited mightn't always love it, but it is for the betterment of healthcare in Ireland. And the final point is that many healthcare subsectors still remain very, very fragmented. So what does that mean? It means as those sectors consolidate, you should be able to get businesses that are larger, can invest more in quality, can invest more in training and their people, and also maybe can provide better value to whoever the payer might be. So what do investors say is their wish list? I'm delighted to see the conversation later on about how we create a better staff experience, better employee experience in the healthcare sector, because that's number one. Whether you're public or a private provider, the challenge around ensuring that you have enough people on your team to provide the care to the quality that you want to provide it is a universal point. There's no doubt that we're losing a lot of young people to better weather or better money in other countries, but it's not just about that. We obviously can't just accept that that's always going to happen, that we lose a lot of people for those items. The best clients I work with in this area, they're investing a lot in wellness. They're investing a lot in the working experience, what stresses people have in work and how they're managed. And they're investing in training, whether that's training inside in their business or more wider within the economy around redirecting people's careers who may have got through, may have had the great resignation through COVID and decide they want to lead a life that has more purpose, and getting those people into healthcare. Inflation and cost recovery from a financial point of view has certainly been one of the biggest points on the investor, and we see it in the not-for-profit space as well. How inflation has been passed on ultimately to the payer. And I have to say, talking to investors in different countries, other countries have been better at it. They've reacted quicker. Now, there's a natural tension when prices are going up. Nobody wants to pay more. People have restricted budgets, so you can understand why that tension is there. Now, hopefully, though, hopefully inflation is maybe under control for the time being. But we went through a period with very, very little inflation for a couple of decades, and that's an unnatural period. And it'd be naive of us to think that we won't face significant inflation again over the course of our working careers. So I think that provides an opportunity to say, okay, well, we may be through the storm, but there probably will be another storm. So can we stand back and say, are there ways we can look at our payment structures to make them more robust and to allow them to react to inflation quicker, so that ultimately operators can focus on service delivery and not have to worry about escalating payroll or food costs or whatever they might be. There is a real challenge at the moment around the capital intensity, the cost to build, the cost of delivering new facilities, and also the cost of capital, which has slowed down investment. Now, some of these items, it's very hard to solve. Okay, the ECB may reduce interest rates a little bit, and that could help. But the cost to build is a universal issue. We see it in residential as well. From an investor point of view, you would like to see, in other markets, you see an awful lot of use of insourcing and other ways just to sweat assets more. And you do wonder, is there opportunity for greater public and private work cooperation just to get the most out of the very, very expensive assets that we have, acknowledging that we do need lots of other assets, but can we get the most out of the existing estate? And the final one here around longer-term partnerships, I think for a lot of us, this has been on the agenda for all of us for a long time, that just a better working relationship between the public and private. And during COVID, it worked really, really well, and we still have some of that dividend from how the public and private really, everyone put the shoulder to the wheel and got to better outcomes. But as in Europe earlier in the week, and I'm deliberately not saying which country, and a very senior healthcare executive, we're talking about the marketplace generally, a very senior healthcare executive said to me, David, like in Ireland, like ultimately, the government don't want the private sector in healthcare, do they? And I was giving all the great examples of, where private healthcare works really, really well in Ireland. But like I was really surprised I got the question. And this is not from, this is somebody who is very invested in healthcare through Europe. And you would just like to, I guess, from my point of view, like I'm going to approach the world primarily through a financial and commercial lens. But ultimately, the state gets a better deal if there's longer term arrangements whereby capital can know it can go in and get a return and have a multi-year investment. And I just really encourage, I know that there is a lot of work in that area, but certainly from the investor perspective point of view, what we're seeing is the investors are very much up for that. And we've done it before, and we've done it really, really well. So instead of come back to primary care, so it's a HSE government initiative, government policy for the rollout of primary care centres in Ireland. And in 2010, we had 42 primary care centres, and in 2022, we had 4 times more. And it's just a fabulous example of, and they're delivered both by public and by private, I should say. But it's a fabulous example of public and private working very, very well towards a common goal that ultimately we all know will have a massive impact on the welfare of our people. So that's it for me. Thank you very much for listening, and see you at the coffee break.
Thanks, David's very much appreciated, and it was very interesting. And I mean, as a primary care physician, a GP myself who was involved in one of those primary care centres, it is a great example of public-private partnerships and where it really moved the needle. And I think your discussion around insourcing is really interesting as well. So it'll be really interesting to have further discussions on this. The future is already here. It's just not evenly distributed, as the quote goes. We've had discussions this morning on the RHAs and Sláintecare implementation. And I think really the elephant in the room is integrated care. We've got primary care, community care, hospital-based care, secondary and tertiary. And how do all of these different parts of the healthcare system interact? So the next discussion will be on that. And I'd like to invite our first speaker on it. He's Dr. PJ Harnett. He's the head of integrated care with Molam Care Services. PJ is living on the Limerick-Kerry border. He's very specific about that. I think there's a stream, at the edge of your property or something. And he's a registered psychiatric nurse by background, holds an MSc in nursing, an MBS in healthcare management, and has a substantial clinical, academic and operational leadership in this space. So I invite PJ to join us. Thanks, PJ.
Thanks very much, Tom. I'm mightily relieved that the speakers this morning have picked up on many of the things that I'm going to talk about. And the kind of central theme of what I'm going to talk about today is essentially that message around silos to systems. Many of the opportunities that David had talked about has really resulted from the fact that much of what we do in terms of our design of healthcare systems and the planning of healthcare systems and the utilization of the assets that we have is very much based on a siloed approach to healthcare. So I want to give a little bit of context. That's been well covered in terms of lots of demographic data examples. I want to share a few thoughts on the future of healthcare and where I think we need to get to. And this is not just my particular opinion, but this is very much the direction of travel internationally when you look across at health systems who are facing the same challenges. And I want to talk in particular about whole system collaboration and what that might look like. And we heard a lot about governance this morning, and I want to talk about a new form of governance that's very much recommended by the WHO and the European Observatory for Health Systems. So just a quick reminder, Molam Healthcare, I joined 3 months ago, very proud to be part of the Molam team. And they're the largest provider of healthcare care centres in Ireland. There's 2,000 beds, there's around 2,000 staff working in those centres, and they provide a variety of care offerings, both long-term care, but also particularly the memory care program, and rehabilitation is something that we're increasingly focused on. So this morning there's a number of discussions about the healthcare system and the future of healthcare and what that might look like. And I'd invite you to think about for a moment what you feel the biggest challenge in healthcare in Ireland is. And I'm sure, depending on the position that you're in, the lens that you look through healthcare from, that you'll have different perspectives on that. We've heard about the profound demographic changes and the impact that that will have on the sustainability of healthcare going forward. And that's a challenge that every healthcare system in the world is facing. In integrated care terms, when you look at healthcare of the future through that lens, the biggest challenge for people who receive healthcare, but also the planning of healthcare, is in managing complexity for all of the reasons that we've heard from Dr. Colm Henry this morning about the nature of the healthcare population, the growing comorbidities, and the increase in chronic disease. But for me, the biggest challenge in healthcare is fragmentation and lost opportunity. I think some of what David O'Kelly has referred to touches on that. That there is a lack of alignment between assets and effort. There is strategy perhaps that isn't necessarily always aligned, therefore allowing people to plan into the future. Huge amounts of data that we don't necessarily share or tap into that would bring a greater benefit for the population. The need to think about the workforce and how we incentivize people to stay and work with us in Ireland, and so on and so forth. So in Molam, our vision going forward is to anticipate that population need, but also to work in an integrated, age-friendly health system. And I use that word age-friendly health system very deliberately because it's a specific meaning in terms of what constitutes an age-friendly health system. And what constitutes an age-friendly health system touches on some of what was talked about earlier in terms of governance and in terms of what it is that we measure and what we talk about. So from a Molam point of view, the kind of different services that we're considering in terms of that age-friendly and integrated lens includes rehabilitation and post-acute care, the demand for which and the need for which is grossly underestimated. The need to continue to focus on the Molam Memory Care Programme because the number of people with dementia is going to grow significantly. Higher quality residential care, but also particularly this idea of long-term care in the home, that people want to remain at home. So how do we rethink what we do? And again, interesting to hear about the kind of investment opportunities. When one thinks about the future, it's difficult to think about what we are going to do immediately about that because it kind of feels like it's some distance away. And I remember when I started in integrated care in 2015, the big kind of burning platform at the time was that if we don't do something different then, we'll need to build a multiple of new hospitals in order to cope with demand. Well, we haven't done that, but the problems have remained largely similar in terms of a changing demographic. And one of the things that really strikes me is the failure to think about and plan for the future in an aggressive, assertive way means that things like high technology drug costs, long-term residential care costs and home support will grow to a scale that is going to be unsustainable based on the current paradigm of thinking and planning about how we meet healthcare need in Ireland. I spent the last 7 years working in integrated care for older persons. It's a really fantastic role to be in. And one of the things that really struck me about that, similar to work that I have done in the past in mental health, was the corollary between mental health and older people, but in particular for older people, the need to recognize them as a distinct group with distinct needs, and in particular, not just the quantum and volume of people that are growing in the population, but what it means when you reach a certain age in terms of healthcare utilization. So you'll see on the graph that we can predict with great certainty the amount of elective work that would need to be done over time. This data is from 2022. In terms of unscheduled emergency care for older people, after the age of 75, the utilization of healthcare, and in this case bed days, but it could apply to a number of other different types of healthcare utilization, grows incredibly substantially, whereby the proportion of healthcare resources consumed is done so by a relatively small cohort of the population. And So we tend not to think about and plan for tomorrow. We kind of also are caught up in today. And when I looked at the data for the first 5 months of this year, when we look at the number of people over 75 who will present in the emergency department this year, we know with a fair degree of accuracy what that will look like. So we know this every year, but it shouldn't therefore be a surprise. We know that around 50% of these will be admitted, and that number has changed over the last 10 years. And the number of people, the number of bed days they'll use has also increased over the next 10 years. So the core business of healthcare in Ireland ultimately is really around older people. When we think about the future of healthcare, if you look at countries like Singapore, Belgium, Australia, some parts of the health provision in the States, there's a real recognition that we need to shift our thinking and the paradigm from what we've always done to what we need to do. And this particular shift is based on the idea that what we designed healthcare for 50 years ago is no longer fit for purpose. And the shift from today to tomorrow represents the kind of changes that are needed in the model of care and in the way we think about how healthcare is provided. So I'm not going to go through all of these points, but essentially today we base our healthcare planning on acute episodes of care, and we've done that really well. We base it on cohorts of diseases, and we organise specialties around that, as opposed to need, which is much more multi-morbid and complex. And we also design care in a way that's inaccessible and fragmented. And what we need to shift to is a much more relationship-based approach to care, where we have a longitudinal involvement with somebody based on the kind of things that Nick Young was referring to earlier on, identifying people early, coordinating their care, delivering care close to home, and rethinking those models of care. The second strand of what is dominating the conversation around the future of healthcare is integrated care, and it's a term that's been around for years. In 1988 in Ireland, there was a Years Ahead policy published. The ingredients of the Years Ahead policy in 1988 are no different to the ingredients of integrated care today. They talked about local needs-based care. They talked about the need for specialty teams working with older people, and so on. And in integrated care, there's a really elegant definition by Liv Lennox-Chigani, which is about coordination, continuity, and in particular, measuring outcomes that matter to people. And within that, there is a need to attend to three different aspects of this. The need to think about a population-level approach, a systems approach, to think about the need for disciplines to work differently, and also to think about a much broader definition of integrated care that leverages all of the assets in an ecosystem that means that the health system in and of itself isn't responsible for healthcare. This is a variation on a piece of work that I was doing in my previous role, where we looked at a high-level conceptual map of what integrated care for older people might look like. And what I wanted to do with this slide is really to emphasize how that mix of public and private exists in reality in that ecosystem as we speak. From a Molam point of view, Molam is involved in residential care, end-of-life care, and rehab and community care provision. And we are part of that ecosystem. And the shift left, essentially, I think, will involve that public-private community, voluntary and NGO coalition, collaboration to drive that shift towards what essentially people want, which is to remain in their own homes for as long as they can and live the lives that they choose. Very briefly, in the context of regional health areas being established, Sarah Barry and her colleagues in Trinity did some research into 30 years of reform in Ireland. And the lessons that they found essentially point to the fact that there were common mistakes repeated over time, and the insights that she was offering have to do with better governance, being bold in the vision, but acting as a system. So, governance has cropped up a lot, particularly in terms of hard governance, accountability, making sure that the right things are done well. And it was gratifying to hear about the core of that being around ethics, values, and purpose. This is a brief synopsis of work that Caroline Nicholson has done, but it also reflects the European Union Observatory recommendations on governance where private and public sector healthcare systems work together post-COVID. And so essentially the new forms of governance need to reconsider how we go about governance, involving patients and carers in governance directly, ensuring that they are sitting there as part of the design, having accountability and transparency in everything that we do, being bold and innovating, and as Robert Watt said, failing fast, being clear about what it is that we're trying to work towards. If we've agreed on a model of care, that's what we need to go after collectively. And also developing intersectoral collaboration. So in one example there, the Healthy Age-Friendly Homes Programme, Age-Friendly Ireland, the Department of Health, the clinical programme for older persons and the local authorities collaborated on an initiative that's a phenomenal example of integrated care. Well worth having a look at that. So in Molam, we are working on each of those elements of governance and the elements of integrated care that we've talked about. In terms of strategic planning, we use multiple data sources to think about what it is that's going to be needed. There's really strong layers of governance throughout the organisation. Really loved what was being talked about earlier on. I've noticed since I've joined Molam that every conversation at every meeting is data-driven, really objective measures of what matters and a real scrutiny on problem sensing, looking at what it is that's happening in terms of patient quality of care. There's a lot of work being done on workforce in terms of Molam Academy and learning management platform to try and retain and educate the staff, and also an openness to innovation around digital technology and transformation. So I wanted to give a quick example of patient experience being measured as well as outcomes, and hopefully we have some sound.
Really very grateful to the staff here. They're excellent, so good, so caring.
The people all the time, hey, how are you? Smile. You don't see anybody stressed.
I'm from Tipperary and I came up for surgery in Dublin. I live on my own, so for recovery purposes, the doctors advised me to stay local because I'm so far away. So they recommended here, settled in straight away, everything was done. They unpacked my bag, they hauled my clothes. I had literally nothing to do, everything was done for me. That takes away the anxiety and the pressure that you would feel being moved around, especially when you know nobody and have no relations in Dublin. This was just worked out. A dream, I couldn't recommend it enough. Well, they've been brilliant. I've had OTs in, I've had physios in, I've had dietitians in. They're all in sync, it's unbelievable. So by the time I go home, I'll be strong and fighting fit.
I broke my tibia. I need to fix it, need a physiotherapy. Well, I stay here for the last 4 months. I can't complain about anything, so everybody is amazing, great stuff. Everybody do the job with the love, you know what I mean? Great place, I can't complain about anything. The physiotherapy, they come to me every day to check my progress, to see if I do it properly, exercise, how I walk. I'm happy, so I can't complain. When I finish my rehabilitation here, so I pretend to back to normal lives, to go to my Italian coffee shop, drink a coffee, eating a croissant, enjoy the sun outside, something easy that you don't appreciate enough.
I'm here because I had an operation in hospital to get physio and to get mobile. My transition from hospital to here was smooth and fast. They did their best. I was over here, I'd say, in about 20 minutes. The staff keeps me informed all the time about my progress, what medications I'm getting, when I'm getting them, and what they're for. The therapy and nursing care I received was second to none. They could not do enough for me. Every member of the staff. This place is like a home. So good, so caring, and I miss them all. And I'd come back and visit them.
My transition from the hospital to here was amazing. It was very fast. The nursing care is fantastic. They're absolutely wonderful. Couldn't do enough for you, actually. The social end, the dining room is one part, is amazing. It prepares you, it keeps you adrift of what's happening outside in the world. When I come here, I couldn't hold a cup, and now I can drink normal cup of tea. I feel I'm improving every day. I'm really very grateful to the staff here. They're wonderful, really wonderful, not just to me, but to all the other patients as well. And I'll forever be grateful to them for helping me.
So, in terms of patient experience, as one of the metrics that's key, we framed the questions in that video around an age-friendly health system metric. Four indicators of what matters to you in terms of the outcome you want, information and involvement in your care planning, and issues around mental health and mobility. So very quickly, I'm conscious that time is up. We also are developing and have been working on outcome measures. This is a quick snippet of outcomes in terms of people who leave acute hospitals, go into rehabilitation and the outcomes they've had. And all of those outcomes were planned. So the 8% who went to a nursing home was part of the actual intended destination. So finally, the key messages are that there is an urgent need and opportunity to develop and be the first in the world for a sustainable, integrated, age-friendly health system. We're the first in the world to be age-friendly through Age Friendly Ireland with cities and counties. We have a national affinity, a natural affinity to collaborate, but this isn't just about potentially collaborating. We absolutely have to do this in order to have sustainable healthcare and to leverage all the assets. There is now an opportunity with the RHAs to integrate a new form of governance into how things get done. We, and I'm sure all the other providers, want to be part of that solution. And a final point, Colm Henry has gone, but one of the things he often quotes is that older people are not the problems of our health system, but the purpose of our health system. Thank you.
Thanks, PJ. Thanks a million. Thank you. Yeah, that's a lovely quote, and it's becoming more and more clear just the challenges we have in terms of age demographics. And it was really interesting to see that the largest demand will be up in the border area and down in your area in terms of geographical space. So the next speaker is Dr. Emer Hearn. Emer is the National Clinical Advisor and Group Lead on Older People and Clinical Design and Innovation in the HSE. Emer is a consultant trauma and ortho-geriatrician from Cork University Hospital. She's the National Clinical Advisor and Group Lead for Older Persons in the HSE and the President of the Irish Gerontological Society. So thanks, Emer. We look forward.
Good afternoon now, but thank you and thanks for the invitation to speak. It's great because I think actually most of my talk has already been kind of given this morning. So I think like what I'm going to talk about today, and I think kind of inspired by Mary and Kieran and Colin this morning, is I'm going to give a summary of my talk before I start. So one, I'm going to call out, and name the elephant in the room. And two, then, what is the right thing to do in response to that? So I trained in Liverpool as a geriatrician, and I returned in 2005. And when I was reflecting and planning kind of the presentation for today, I just said I'd look back in terms of like when I arrived in Ireland in 2005 and what was going on then, and certainly then what's going on today, before talking about kind of future care and future planning. So in 2005, so Mary McAleese was the President of Ireland, population of just over 4 million. At that time, there was nearly 500,000 older adults living in Ireland, representing kind of about 11% of the population. So interestingly, even though I wasn't aware of it, that was when the HSE, as an entity came into operation in 2005. Trolleys were still kind of prevalent and talked about in 2005. And the life expectancy in Ireland in 2005, when I returned from Liverpool, was 79 years of age. So over the course of my lifetime since I've been born, so 11 years has been added to our life expectancy in Ireland, which is absolutely taking away everything that goes on is a phenomenal achievement for healthcare, for government, and for our society. So today, from the census, we have a population now of well over 5 million, so an extra million people in the population. We now have nearly double the number of older adults in the 20 years. So when people talk and they don't feel connected with the fact that we're going to have this aging demographic that everybody has been talking about over the next 20 years, we've already had it, we're already part of it and living it at the moment. We now have the health regions and this new kind of organisation of the delivery of healthcare, which PJ has always talked about more eloquently than I have. And we still are talking about trolleys. And I just want to specifically mention this because I think we're actually almost dangerously defining kind of what we're doing by trolleys every day. So they were present in 2005, they're still present today. And what it does is actually pulls the narrative into a very narrow kind of tunnel vision of what healthcare and healthcare delivery it is. It is really, really important from a patient safety point of view to address trolleys and why people are on trolleys and all the causes of that. But it's actually hindering the wider conversation that we need to have over how we're going to deliver healthcare into the future and how we can best do that. And now the life expectancy is 82 years, just over 82 years. So again, even since I've been here and working in the healthcare system, life expectancy has improved. And when you look back, and I must say, like in my role as national advisor, I'm always the one on the calls, you know, whoever, it's like raising hand, kind of challenging and interrogating all the policies and the strategies. But what we have done in the past, what Ireland has been actually remarkable in doing from a government and healthcare perspective, that we have improved life expectancy. We're probably one of the leaders in the world in how many years we have added to life. And this was because in the approach, and when you look at it, the approach that we took is that we identified high-risk populations who were dying, you know, for unnecessary reasons, are being harmed by unnecessary reasons. And we tackled those in all the policies and the strategies that we had. So in the early 60s and in 70s, you know, children were dying, infants were dying, mothers were dying, you know, unexpectedly, you know, and there was a huge focus on that. So much so that infant mortality, maternal mortality, we're now one of the leaders in the world in terms of that. Then the next focus was on people in their middle ages having heart attacks, strokes, cancer. So there's a huge focus on that. And again, Ireland is one of the leading countries in the world in terms of interventions in stroke, interventions for heart attacks. And we heard this morning from Robert Watt about the remarkable gains of people diagnosed with cancer. So that is just phenomenal achievements that we've doing. So we really have taken something, we've taken cohorts at high risk, we've really addressed them through policy, through healthcare strategy, to delivery of care, and we have improved things even over the 20 years that I have been here. But then when you look to the future, then what are we going to do? So lots of people have referred to the aging demographic this morning. So we need to shift. We can't continue to focus like that on specific cohorts in the same way that we have done before. It has to be done differently. So our traditional way of delivering healthcare is that a person is sick, we treat, we send them then home to either get better or to die. And that's what our traditional system has been. And you can see it has served us really, really well in the past. We have done exceptionally well there. But that is not fit for purpose going forwards. That is not going to meet the needs of the people who are coming into our healthcare system now. So the profile of people who are coming in, so given that life expectancy is now, it has changed, it has shifted. So people aren't presenting to any of the continuum of services that you represent today. None of them are coming in with one thing wrong with them. In fact, that is really, really rare. They are coming in with lots of things wrong with them and very, very complex. And the outcomes anymore that people want, as PJ's video just showed, isn't to die or get better. People want more than that now. They want to be able to have a cup of tea. They want to be able to go, I was just envious and just thinking of that coffee shop with the croissant. That's what people want to be able to do now. And that's what our healthcare system needs to be able to deliver to do for these people. So we're gone beyond just living and dying now. So it is about talking about health expectancy. How is our health going to be better into the future? So again, we've probably referred to this just in terms of I think we're at a really pivotal point in our healthcare delivery system, So again, we really have done the right thing. Healthcare regions, population-based planning, population-based funding, that's all the right thing to do. we're actually doing it. We're at the start of something, of doing the right thing. All the international evidence, all experience from other countries tell us that we are doing the right thing. So we're really at the start now of a massive opportunity in our healthcare system. And then I think a lot of people have. So in addition to the aging demographics, what we're actually seeing, in increased demand, there's more demand over and above what has been expected from that. And there's a lot being written and looked at into now over why this is the case. So one, and David, one of the Davids alluded to earlier on, saying that we've the fastest growing. So we're actually still a relatively young country, but we've the fastest growing aging population. So that's just translating into a faster demand that we have at the moment. So all this demand that we're seeing and people are going, where's all this coming from? That's just part of the demographics. It's rapidly increasing, so we're going to see this rapid increase in demand. But also, and what's coming out from some of the longitudinal studies in England, and I think Ireland will report later on this year, is about the increasing prevalence of frailty post-COVID. So before, there's more people who are frail after COVID than before. So that's probably as a result of, one, the direct effects of the virus itself, but also two, the whole our response to it in terms of lockdown, kind of isolating people, social isolation, lack of networks. And then three, we've seen a change in the pattern of the way older people are using services. So they're using healthcare services more and more. So this again is over kind of what would have been expected kind of from before since COVID. And these remain kind of persistently elevated. So when we talk about the healthcare system, one of the things that really actually drives me kind of like just absolutely mad is when this whole narrative about older people being a problem and a burden. And when we look at our healthcare system and what it's doing, older adults as a cohort, they benefit the most from what we're doing every day. So in terms of access, and I'm just listing there, and I hate putting on loads of things on a slide, but I actually thought it was really important today, and I'm not going to go through them, but it lists all the services that older adults access every single day in our country and benefit from our healthcare system. So they are hugely benefiting from the services that we're delivering. But also then paradoxically, they're also harmed the most from our healthcare system. So they're getting really good care when they need it, but they're also harmed the most. And you can see that by the huge variations and all the harms that we hear about. So they're on trolleys in the ED, they've the longest length of stay in hospital. They get sicker in hospital rather than getting better. Everybody talked about delayed transfer of care. They have a higher institutionalization rate than any other cohort. They have a higher mortality rate. They have a higher readmission rate. So again, really harmed. They're also less likely to be involved and supported in decisions about what they want and need. They're less likely to be prioritized for health promotion and disease prevention. So all the evidence for health promotion and disease prevention, there's a huge amount over the lifespan, including in the very old, but yet they're not kind of like included in all those campaigns. They're more likely to be either mistreated, undertreated, or overtreated. And also they're less likely to be included in any research or education curricula in our universities. So I'd just like to talk about I'll digress now. So I think the real thing that we have at the moment is that it's not like that we have the demographics. So that's just the truth. We have an integrated system being delivered, and PJ has talked about the governance that needs. So anyway, so that's a really good opportunity. But what we don't have is that we don't have a system designed for older people. It isn't designed for them. We haven't done that. We treat them just like everybody else, kind of like who's accessing healthcare. And that is fundamentally wrong. It's causing harm. And no matter how much capacity we bring in or we invest in, it's going to be of no use unless we actually design what we're doing better. So when I'm talking about so Van Halen, so I don't know if any of you know the story. So they were a big rock band, and they were the first rock band to put on kind of really complex performances. So they had loads of kind of high voltage equipment, pyrotechnics. So they were the first group really to ever do that. But when they were going to their concerts and putting on their shows, they used to have pages and pages of a contract rider, which was over to the organizers of the concert to say kind of what you should do and all the things they had to do. And one of them buried in the pages was that you needed to have a bowl of M&Ms kind of behind the stage, and all the brown M&Ms had to be taken out. So that was it. And everyone's going, oh, this is like real diva story, kind of rock and roll story. So this wasn't. This is the most elegant kind of like risk assessment story I've ever seen. So they knew that if they went into a venue and if they went to the bowl of M&Ms and if there was a brown M&M in the bowl, then the attention hadn't been made to all the other things that they had asked for in their rider. So the site was unsafe and they couldn't put on a concert. And they cancelled concerts when that happened. So I like to think of this as like in terms of how we're going to deliver healthcare. So we're approached in a real homogeneous way. And this is the way that we believe that we're currently still going on that route of delivering healthcare like that. But what you need to do, you need to take out the high risk kind of population in that whole cohort and then apply a system and a framework that will ensure the sustainability and the resilience and the safety of the system that we're working in. Now, I know I've gone over, but I'm going to... So when we talk about this, I thought people might recognise this. So up the road, the Children's Hospital. So again, in Ireland, what we've done, we've actually built and designed an infrastructure and pathways for children because they needed it and they benefited from it. So we did that because they have all these different needs. So that was really the correct thing to do, and we should be really proud of what we've done for the children of this country. But what we have not done is actually the same for older adults. And they too have different needs, and they've age-specific needs. They will present differently when they're sick. Their bodies, their minds, their personalities respond differently when they're sick. They need bespoke treatments and assessments to get better, and some of the treatments that we can give can harm them, and we need to know what that's about. They need staff who can recognise that. They need age-friendly environments to ensure their dignity and reduce harm. They need their families, and importantly, unlike children, most children, they need time and access to rehabilitation to recover. One patient described it to me recently. He said, it's like a jigsaw that hasn't been put together. Can you not just put the system together so that we can understand and navigate through it? So how we can do this is by becoming an age-friendly health system, and this is committed to care and excellence for older adults. And in terms of this, what this is, so PJ said that it's a very specific thing, and it is a very specific thing. So what is an age-friendly health system? So an age-friendly health system is a system that uses 4 things and applies it to every older adult, every time, every setting, every profession. 1, you shift the care around what matters to them. Do they want to be able to have a cup of tea? Do they want to be able to go to the coffee shop and get a croissant? 1. 2, medications because of all the harm. Should they be on medications or medications they shouldn't be on? 3, their mind. So to address dementia, depression, loneliness, delirium. And 4, mobility. What you need, how can I help you today so you can live the life that we know that matters to you? So those 4 things. So these are evidence-based interventions that when applied to older adults will improve care, reduce the variations of care, and be of value to older adults, the system, and the people working in it. So we've learned a lot about age-friendly health systems from, So where we've learned a lot about age-friendly health system and where it has been implemented successfully is in the VA system, so the Veterans kind of Hospital Association in the States and North America, which is a bit like our system, kind of, in that it's federally funded and it looks after veterans at every point, and they go across the continuum of services. But they saw aging ahead of us, so they were way back because they were looking after veterans. And they've adopted it throughout every single service in their organisation. So every older adult, every time, gets their care delivered through that age-friendly, through the lens of an age-friendly framework. And I suppose there's been other kind of like healthcare systems that have also adopted it, but they've adopted actually for all older adults. So for like the young gentleman in PJ's video, so for him as well, so you can see how the same principles could have applied to better care for him. So ultimately, I didn't insert this, but I suppose, I don't know if any of you were in Páirc Uí Chaoimh, so on the 11th of May. So I'm from Cork, obviously, but I've also, in my defence, put up reference to excellence in teams like Kilkenny, to Limerick before, to La Rochelle, maybe a bit Cork there. But I suppose when you were in Páirc Uí Chaoimh that night, so you really got the sense that there was like a big challenge like on the table that evening. Like we have a huge challenge that everybody has articulated this morning. But you also could get the palpable sense that evening that there was big opportunity. And again, too, we have a massive, big opportunity with the regions, with the governance and the structure that we are implementing at the moment. But one fundamental thing needs to change, and we need to change the way our healthcare delivery system is designed. It needs to become an age-friendly health system, because otherwise none of it will matter. And I think when I listened back to the kind of the podcast to Jamie Wall, when he talked about that evening, so when he talked about Cork that evening, kind of with the challenge and the opportunity that was in front of them that evening, he said, you have to be brave. You know, you have to take on these things. There's a chance you're going to look like a fool, but we've looked like fools before by doing the same thing and losing the last few years anyway. So it's a fine thing to try something different and try to win that way. So thank you very much.
Thanks, Ian. Thanks very much. That's a great piece of advocacy for us doing the right thing as a country and really reimagining how we deliver elderly care from both of you. And it's a fantastic to be part of this discussion. Our next speaker up is Tanya King. Tanya is the CEO of Piedmont Hospital. She's held senior leadership roles as Director of Nursing and Deputy CEO of the Mater Hospital. Most recently, she'd been Deputy Chief Nursing Officer in the Department of Health. She's also worked in St. Vincent's University Hospital and the Office of the Director General of the HSE. Tanya qualified as a nurse and has specialist postgraduate qualifications and is presently CEO of Piedmont and married off her daughter at the weekend.
I did.
Yep. Thanks.
Actually, I married off my second daughter at the weekend, which is probably my best achievement because all my girls are now gone. Only 2 boys to go. Anyway, thank you very much for the opportunity to speak here this afternoon. And I am going to speak to you about Piedmont Healthcare and about rehabilitation and its role in terms of integrating care. And I suppose I would just start by saying, yes, we have an ageing population, but the World Health Organization has recognized that rehabilitation needs to be available across the life continuum, and that actually providing rehabilitation is one of the main strategies that we should be focusing on in the 21st century to optimizing the functioning of the population. So it's really key that it is available across the whole life continuum. And I'm going to put you into a nice place now, into Zen. If this moves forward, this is Piedmont Healthcare. If you were to have rehabilitation, is this not where you would like to be? We have 65 acres, including therapeutic animals that the patients can enjoy. We sit very much in Sláinte Care in terms of identifying that people's health is changing and care needs are evolving. Living longer, more years, poorer health, and increasingly common for people to have 2 or more long-term health conditions. Patients with chronic conditions require care from multiple providers across different healthcare settings, and fragmented care can lead to poor health outcomes, unmet needs, and excessive service utilizations and costs. So we need to ensure, in terms of the role that Piedmont plays in being that bridge between the acute and the community, that we are actually linking both of those areas and joining up the dots, that we can truly provide integrated care and not fragmented care. So we have a number of pillars within Piedmont Healthcare. We provide both rehabilitation services, community services, and in fact, residential services. But I'm going to talk to you mainly today about our rehabilitation services. We provide specialist, and we're really key in that, specialist rehabilitation services in age-related, respiratory, neurology, and rheumatology. And our aim is to maximize the recovery of patients with chronic conditions or after an acute injury or illness, and to provide a really alternative pathway for hospital avoidance and transfers to the National Rehabilitation Hospital. So as I say, these are our pathways. And then what we have. So we have 45 beds post-acute age-related rehabilitation. We have 25 beds providing respiratory rehabilitation, and that's not really a phrase you hear every day. Those respiratory rehabilitation beds are very rare nationally. We were one of the demonstrator site for the provision of the post-acute neurological rehabilitation beds for patients with chronic neurological conditions or following a neurological injury. And these beds that we provide, these new 15 beds, currently are all for people under 65. And we know from the work that has been done by the clinical programme that within our new regional area, the minimum requirement of beds, those type of beds, will be 60. We have 15 within the region at present. So because we've provided the demonstrator site, we're a member of the first managed clinical rehabilitation network in Ireland, and we facilitate patients to minimise disability and/or maximise functional capacity and independence and quality of life. And then we also developed 10 new rheumatology beds. Blank. Community services. So we provide community services to ensure that members of the local community are empowered to live at home, and again, as has been said so many times, with as much independence as possible. So we have respiratory outpatients clinics, and that means because the clinics are based in Peamount, we can also have direct admissions to our respiratory rehabilitation beds, and that is essentially acute hospital avoidance. We have a day centre for older people living in the community, particularly a number of the people that attend our day centre would have dementia. And again, if they're running into problems, can be identified early and can be potentially directly admitted to Peamount without having to go to an acute hospital. We have radiology and phlebotomy, so our local community can come to us and avoid acute hospital for their diagnostic tests. And we have direct access from home to a specialist older persons rehabilitation programme that I'll talk to you a bit more about. We also have an education centre, so we provide education and training, both internal and external. And our residential services are person-centred, quality-centre residential services for older persons and adults with neurological and intellectual disabilities. So for those of you who don't know Peamount, it's much bigger than you realise. We have 250 beds. So in terms of our rehabilitation programme, again, we spoke about outcomes. It is very much outcome-based. So we are supporting people to walk independently. We spoke about having the cup of tea. What about being able to get dressed for yourself and not requiring assistance to do that? Climbing the stairs, cooking a meal for yourself, not just a cup of tea, getting out and about into the community, going back to doing your shopping as a young person potentially who's had a stroke, may have young children at home. If you can't do your shopping, your life is going to be very challenging. Getting back to work, returning to driving, parenting. So our specialist neuro rehabilitation unit is a level 2B specialist rehabilitation. So we're not the National Rehabilitation Hospital and we'll never aim to be, but we are trying to get some of the patients that might be listed for the National Rehabilitation Hospital off their waiting list sooner. And we've worked very effectively with them to do that. So patients with less complex rehabilitation needs than would require admission to NRH. We have 15 beds and it's a consultant-led multidisciplinary team. All patients come to us from all over the country. They just need to have a home address in CH07 as it stands at the moment, but will in future be in our region. And we are the demonstrator site for the managed clinical network. That portion of our service is currently funded by Dublin Midlands Hospital Group. But again, once it all goes into the one pot, we will be funded through our region. This is some of the referral diagnosis that we get. So really across the continuum, from neurovascular to neuroinflammatory, patients with progressive neurological disorders, and some non-malignant brain tumours. Between 2020 and 2022, I know people always love statistics. We admitted 161 patients. They had an average length of stay during that time of 58 days. So it is slower rehab than you might see in some of the other conditions. In terms of our age-related service, we have 2 rehabilitation units. They comprise of 45 beds, very much flexible rehabilitation for orthopedic, stroke, general age-related rehab. And we have an advanced nurse practitioner-led community rehabilitation inpatient specialist program. And that has, as I said, it provides direct access for GPs within the local community. And we also provide a rapid access service for the Tallaght University Hospital Emergency Department. Again, I like these statistics. This is how many patients we're admitting. And as you can see, we've increased considerably. And what that is about is the work that we have done with Tallaght University and Naas General Hospital to identify the patients that are appropriate for rehab. And what we have done is get those patients to PMount much earlier. So shorten their length of stay in the acute hospital, get them into PMount, and get them started on a rehabilitation program. And once you start them on their rehabilitation program earlier, you can do this, which is reduce your average length of stay and get people home much more quickly. So it's really about working very closely with your acute hospital partners to identify the right patients, get them onto their program early. And as you can see, we've had considerable success in achieving a reduction in length of stay. Our community rehab program, again, a short stay inpatient rehabilitation program. People come in for a 2-week program, but they're only in with us from Monday to Friday. And there will always be that cohort of patients that will focus more appropriately when they are an inpatient for that program. Again, advanced nurse practitioner led, aiming to avoid acute hospital admission. Our admissions really increased post-COVID for all of those people, as you spoke before, that had been deconditioned as a result of COVID. And we scale those beds up and down depending on the required beds from our acute hospital partners. And this is where we sit in terms of PMount, very much part of an integrated care solution in the provision of rehabilitation, working both with the community, direct admissions from an outpatient, direct admissions from an emergency department. And in terms of our CRISP admissions, again, they have risen. And it's a really significant program because what it is doing, which is one of the things that we would aim to achieve as we expand over time, is to actually intervene in terms of preventative rehabilitation. So patient has their one fall at home. They're beginning to deteriorate functionally. You get them into a rehabilitation program and improve their outcomes. And this is a very busy slide, and it's hard to see. But our outcome measures across all the objective measures over time improve with patients who have come in for our CRISP program. So again, because they're in for an intensive 2-week program, it works very effectively. In addition, as I said, we've opened our 10 rheumatology beds just since December of 2022. We've had 98 patients in so far. And again, it's very much a new program, but we will be measuring outcomes over time. So this is our newest program that we've developed with our respiratory colleagues. It's a Reach-In Respiratory Access Service. It's a pilot service which enables the GP to access specialist respiratory advice and interventions from the respiratory team in PMount in order to support the care of their complex adult respiratory patients in general practice. And it means that the pathway allows the GP to access the team and have a consultation. And again, either the patient gets directly into our outpatients or potentially is admitted to a bed in PMount, which again prevents an acute hospital admission. Very much a multidisciplinary approach that involves our physios, our OTs, and the multidisciplinary team that we have. In 2022, in our outpatients, we had just over 3,000 patients, mainly respiratory patients, attending our clinics. And again, very much about ensuring prevention of attendance at an acute hospital. So PMount is very much part of a whole integrated process, ensuring that there is that bridge between the acute hospital and the community, and that we can really provide integrated health services that are managed and delivered so that people receive a continuum of health promotion, disease prevention, diagnosis, treatment, management across different levels and sites of care within and beyond the health sector, and according to their needs and throughout the life course, so that we don't forget also the young people that need rehabilitation. Thank you.
Thanks, Tanya. Thanks, Tanya. We've one more speaker in this panel. Joseph Musgrave is the CEO of HCCI. I think he's coming from the Dáil this morning, where he was doing some lobbying or speaking, and he'll tell you himself. He's led HCCI since 2018 and has brought to it an essential mix of leadership and partnership to Home Care Ireland. He passionately believes in the individual's right to quality regulated home care, and there's no place like home. And that, I think, comes from your mum. I think you said she was in the nursing home business. Through his leadership of HCCI, Joseph has been at the forefront of reforming Ireland's home care system, both in terms of assisting the development of regulations and securing a better deal for the health service for their home care staff. Over the last 6 years as CEO, Joseph has led an important public discussion that highlights the sector and their 12,000 carers, which they do for 20,000 clients around the country. So thank you, Joseph.
Thank you. I have no slides. So I'm going to ask you to rely on your imagination for certain parts of this. First of all, imagine yourself at 90 years of age, which will stretch the credulity of some of your minds more than others. In a world where people who need support to stay living in their own home and community enjoy a personalised, adaptable home care service of excellent quality, you face little or no waiting lists for your care. The care you can get in the community is integrated with hospital-level care provided at home when you need it, with digital and high-tech supports also available. Home carers are paid fairly for the vital work they do, including travel time and mileage, and they have a clear progressive career path with additional skills and expertise rewarded with increased levels of pay. These elements, some prosaic and some more ambitious, of a world-leading home care system do exist, just not all here. Each of these aspects of a functioning, fair, and sustainable home care system are a reality in various parts of the world. Take, for example, Hospital at Home. This service provides intensive hospital-level care for acute conditions that would normally require a hospital bed, but in a patient's home. Care is designed to be patient and family-centred in partnership with this team. And at this very moment, there are more than 70 examples of this across the UK. What's offered in Ireland by health insurers is a much more limited version of this. In New York State, they passed a law in 2015 that enabled greater collaboration between hospitals, residential care, home care agencies, and physicians. A study of home care agencies implementing innovative care models highlighted some pretty promising outcomes. These included decreased hospital readmission rates of 26%, and across just 5 small pilots, savings of $1.3 million. In Ireland, the HSE Home Care Pilot Report has been unpublished for over a year, and the height of its ambition was to try and implement a decades-old assessment tool, Interact. In Australia, an individualised budget for a home care package is assigned to the client, not the provider. The budget sets out the funds available for a person's home care package and how the provider can use this money. It means a person can choose a provider in their area that meets their needs best, and also means they can take their home care with them if they decide to leave that area. In Ireland, some regions of the country, notably Cork, don't even offer client-directed home support, which is the Irish mechanism that allows a client ownership over their home care package. Another Australian innovation is the modified Monash model, which defines whether a location is urban, rural, remote, or very remote. Home care workers receive an additional payment based on the remoteness of the client, again, based on this system. I've been told Ireland is just too small to learn from this example and to try to apply it to rural parts of our country. Japan shows how incorporating technology can support care for those who need help due to fragility, illness, or disability. We've all seen the type of technology in bedrooms that can report when a person gets up from bed, might be at risk of a UTI, records their heartbeat, and can report on areas of concern as they arise. And some Irish companies are developing this technology, but it's not embedded into the current funding model for the home support service. All these examples are clearly good news. All of them could be part of what adds up to a well-functioning 21st home care system here. Our government is getting some things right. We have a minister who supports the sector and has delivered increased funding to enable home care to reach more people who need it. Small progress has been made on the workforce with the living wage and travel time baked into the new national scheme. But, and this is the big but, 5,500 people are still on a waiting list for home care with no idea if or when they'll ever leave that waiting list. We don't publish waiting list times. It means that people could be stuck at home, could be stuck in a hospital or be diverted to a nursing home because they've got no prospect of going back home, despite what their own preference might be. The lack of a fit-for-purpose home care service can mean very sad realities for these people. And getting care itself is an air code lottery. Whether you're lucky enough to get home care and sufficient hours depends a lot on where you live. Take someone in North Dublin and compare them to literally anybody in Cork. The waiting list in Cork is 200 times longer than that in North Dublin. Those lucky enough to get a care package receive on average 7 hours of home support per week, which is perfectly adequate for some people, but simply not enough for others. People may not live close to their family or relatives who can fill in some of the gaps. Families, busy working lives, all of these things stretch resulting care gaps and puts additional strain on families. Another discriminatory quirk of our system is that funding for providers who care with those with disabilities, as opposed to those for older people, receive less funding per hour from the HSE under the current national scheme. A key challenge for our sector is recruitment and retention of workers, a challenge replicated in many parts of the world. And, as you've heard ad nauseum, given a backdrop of increasing aging across the world. Across Europe from now until 2035, around 4 million care worker job openings will need to be filled. And here in Ireland, as I said, we have made some progress. The current national scheme for home support guaranteed the living wage and travel time in 2023 only. We need to build on this and ensure that rate is indexed and mileage is also paid. The first review of the scheme got underway on the 10th of May, and I hope that we will fix these inequities during this review process. Career progression is also crucial to encouraging people into the sector and in retaining them. We've supported at HCCI some great work by SkillNet and RCSI who've looked into this area, and I hope we can share concrete proposals in the coming months once government has been consulted. Earlier this morning, as Tom said, I addressed the Joint Oireachtas Committee on Social Protection and called on the department to review eligibility criteria for state benefits to ensure they don't disincentivize employment. We have a 100-year-old social welfare system designed to get people into full-time work and not acknowledging part-time work as fulfilling in of itself. For example, allowing carers to work just 3 extra hours per week without losing their benefits would significantly reduce waiting lists, support continuity of care, and what's more, 85% of our workers who do claim a social welfare benefit say they want to work those 3 more hours if they're given the chance to do so without losing their benefits. Of course, it's good news that we're living longer, but we need to ensure those years are well lived and that we're not forcing older, more vulnerable people into unnecessarily long hospital stays or nursing home care when they want to and could be cared for at home. We need to build an integrated care system into our communities so that people can receive hospital-level treatment at home. Our acute system will simply not be able to cope as our population ages if we don't reform now. But a long-promised legal right to home care, which was the stated intention in 2016 and 2017, as part of a new overall statutory home support scheme, is not 1 or 2, but now 3 years delayed. The government's so-called Home First promise has become, in short, a bureaucratic nightmare. In recent weeks, the Minister has announced that legislation will be passed to regulate the sector, which we welcome, but I doubt it's a sign of new energy this late into the government's term. As I've outlined, we've made baby steps, but baby steps only. So really the question is why? Do we not care about this issue about home care? Do we not value the workers that carry out the work? I think we do, but we lack a collective vision for the home care that we want. There's no real goal. And to get the home care we need, we first need to visualize what we want and then act. When the US Social Security system was designed in the 1930s and the NHS was being established in the UK in the 1940s, there was a very clear vision for what was needed to care for people, and it was a very specific response to developments at the time. Our government must have an equally clear vision for what they want to achieve from an integrated and community care system, or it simply won't happen. The question must be asked how relevant Sláintecare remains to this moment, and if it is our vision for the service, and remains so, the transformation still required demands backing from across government and not just the Department of Health. It's only when we're clear about what we want from our future that we can put in place a system that will fund and sustain it. In my view, we need to share a vision for a transformative legal right to home care. It should be a unified home and integrated community health system, equipped with innovative technology that caters for all over the age of 18 and embedded in each health region. And there should be a rational split and long-term partnership between the private and public sectors to offer choice, resilience, and incentives to keep improving. Our vision for home and community care must be ambitious and designed today so there can be a brighter tomorrow. We know that elements of what we want are being done in other parts of the country, in other parts of the world. And we can learn from them to develop a system in Ireland to be proud of. We owe it to our loved ones, those living with disabilities, those who work in the sector, and our future 90-year-old selves to get this right. Thank you.
Thanks, Joseph. I mean, what's been interesting is all 4 presenters have really laid out a very passionate ambition for care of the elderly in the future in Ireland and how we need to deliver on this. But dare I say it, there's a lot of experience here and people who've lived with this for a long time. What at a practical level, because it sounds a little bit like we have an opportunity here to move forwards with the new integrated and regional health authorities, how at a practical level, what do we need to do? PJ?
Yeah, I mean, I think 2 things that strike me. One is the last comment by Joe, which is we need a clear vision, and we have that.
Yeah.
We need a structure. There was an integrated care plan for Northern Ireland developed by a guy called Rafa Bengoa. He talked about structures, systems and not structures, but we need a structure, and we have a structure now in the RHA.
Yeah.
And as I said, we need a different form of governance to be able to drive the vision and hold everybody to account. And the other thing we need to do in that governance is not be thinking about patients and providers, but involving people in the process. So we have to have, back to the good governance discussion this morning, we have to have citizens who are beneficiaries of the region as part of that governance structure. And if you start with them in the governance, with a clear vision, and begin to measure things that matter. So measuring the things that matter to people is a tangible manifestation of what's happening on the ground. So what are the outcomes you want, as opposed to the lakes of data that doesn't give us what we need to know about what it is that people want from a health system. And the other thing we need to do in that governance is we have to include other parties, be they, we saw this during COVID, sports partnerships, local authorities, community and voluntary groups, because those are the people that are involved in the day-to-day stuff that keeps people well, because we know that the health system only contributes 15% of the healthcare dividend. So all of the other things that are important to people, whether they're the GAA or whatever it is, need to be part of that response. And that new governance structure is an opportunity. And we already have the exemplar. The WHO last year, when it published this review of a decade of healthy aging, referenced Ireland as an exemplar internationally through its age-friendly cities and counties. The local authorities host that, and they address everything from transport to the built environment, etc., etc. And as I said earlier on, Emer and I collaborated with Age Friendly Ireland on a Healthy Age Friendly Home initiative, which is a really practical manifestation of how do you keep people at home for longer and delay the potential for them to need long-term care and so on. So I think, it's a bit like John Hume's single transferable speech. I don't think we need to invent something different or new. I think we need to do what it is that we know works.
Yep, agreed. And look, we all share the aspiration to look after the elderly citizens of this country well. And, it's a critical thing that we do, and we do it properly. Emer, you've been at it a long time. You said you've sat in a lot of these panels and advisory groups. What do you think? I mean, you made a very passionate argument for it. What do you think are the practical things we need to do?
I think what PJ has talked about, I think that governance, that kind of like wider kind of collaborative governance is key, that involves all the stakeholders across the continuum. I think it's really important that we value the elders in our society, and I don't think we do that actually, when it fundamentally comes down to it.
Do you really believe that?
So I think actually that there's fundamental ageism.
Yeah.
And I think when you look at it even internally amongst ourselves, internally amongst people who specialise in the care of older adults, so I think that there is in research there is ageism, in academic kind of institutions, in education curricula there's ageism. I think in clinical scenarios, most of the older adults are actually receiving treatments that are based on the outcomes in people's in their 30s and 40s and no cognizance of the harm. So I think there is that, and I think even amongst kind of older adults themselves, so older adults will often go out and they will advocate for their grandchildren, and they will advocate, for better education and that, but they are less likely to advocate for themselves. So I think there is, in our country, I think there is, fundamental ageism that's underlying. And unless we actually kind of really have a robust and strategic response to that, I think it's going to be very difficult, to implement all the solutions that we have, And that's why I think in the governance that, in my ideal state, that you would have, whether an executive or a board, and we talked about it this morning, that we need to kind of say that older adults are the experts in what they want. So all of us, whenever we want something, we are the experts. So really shift to they're the experts, and that we kind of, in whatever we're doing, in kind of whatever facility domain we're working in, we're kind of outside that as the people who can help and support them to get what they want. And that has to be, so that there has to be that fundamental shift in the way we think in our structures, in the governance, in the care we deliver.
Sorry, you were going to say something,
Yeah,
PJ?
I was. I mean, again, it goes back to how we include people in the process, not just at a high level in terms of governance, but also in the design of services and what they want. So I remember in the course of the integrated care program implementation, we always recommended at least 2 older people who were nominated by Age Friendly Ireland to be part of the redesign of care pathways. And they completely changed the dynamic when they're in the room. So big long sheet of paper describing the care pathway. And if it's a conversation that just involves clinical staff or managerial staff, you'll have the same conversation. But if you involve people who are using the service or who can describe what matters to them in terms of an outcome, they will be able to cut through that dynamic and say, this is what we want, that doesn't make sense, why can't you do this? And very often what they want isn't necessarily anything as convoluted or complex as what the clinical perspective might be. So at a practical level, you need to involve people at various layers of change, and also have them involved in continuing to monitor the implementation of that change.
And I think practically, sorry, you know, that's
you're
what
okay.
that's you know the agility and the elegance of that aid-friendly health system framework is that it can be applied. You can deliver all care through it, and it basically is around kind of what matters to the older adult and building a care system kind of around that. So that's why I think
I found that very exciting, actually, to look at it with that lens and the simple things you were measuring and what was really important to them. Joseph, obviously, you're a young person advocating for older people.
I am. Yes.
Tell me about that.
Well, I go back to your original question, really, which is, you know, what practical steps do you take? My point was that you can get mired in incrementalism.
Yep.
You know, who's involved in this and what's the funding model and who makes this decision? My point was with Social Security and NHS, sometimes you've got to take a leap. Incremental steps aren't going to get you very far at a certain point. And I guess maybe because I'm younger, I want to take the leap.
Yep.
We said we'd make a legal right to home care in 2016 and 2017. The Taoiseach in 2020 said that scheme was ready to go, and then bang, it disappeared. Why? Because they're afraid of what it means. They're afraid if they give you a legal right to home care, you're suddenly going to say, well, I want hospital care at home, or I want the system designed around me because I'm an older person, I'm using it.
Sure.
And they're afraid of that.
Yep.
So I think we need to push.
And why are they afraid of that?
Because it costs money. Because it costs a lot of money. And they're staring down the barrel of it, kind of going, we want to protect the fact we've got the Shared Ireland Fund, or the Future Ireland Fund, but we don't want to blow it all on something that we can't cost, or we're afraid to cost.
And some of it's because they don't understand it clearly and they don't understand the implications of the costs. But if we're looking at that tsunami of costs coming down the tracks, you know, as the population ages, Tanya, just obviously you have a slightly different model in the sense you're a Section 38, a standalone entity.
Yeah.
Yeah, talk to me about that. And
So I suppose we are, although we're funded by the HSE, we do have a certain level of freedom to perhaps develop services or to focus where we're trying to go in terms of our direction of travel. And certainly from a PMENT point of view, we've identified the requirement in terms of rehabilitation and, as I said, that sort of prehabilitation bit. So in that continuum of care, that we would ensure that people are optimized, so their functioning is optimized. Whether, you know, and in a model of the ideal world, for me, for an older person, in an ideal world would be that care is at home, but they come in for perhaps that 2-week program that optimizes them so that they need less services and it costs less to keep them at home because their functioning has been optimized. So in terms of our development, that's where we'd like to see ourselves going forward. And you know, we would obviously like the HSE to fund expansion in PMENT where we have capacity, but you know, that's the kind of model that we can have the freedom, I suppose, to develop because we're Section 38.
yeah, and that's interesting in itself. And obviously a little island of innovation that you've been off doing these things and making success. And you have a little bit of autonomy to do.
Very interesting what you were talking about earlier, because we've been working, and I see the Sparks program are here, the HSE program, to look at that rehabilitation pathway. And we involved our service users in that. And it was the small things, like look at the meal times, you know, can we have, you know, for a lot of people, for older people as well, they now eat their dinner in the evening. They don't eat it at lunchtime where traditionally they would have. So was one of the things that came through. Can we actually have our dinner at tea time rather than at lunchtime? And so we're exploring all those things so that they can also optimize their time in rehabilitation.
Yep, thank you. Joseph, just on the technology side, because I'm conscious that, you know, there's a huge opportunity there. I mean, what do you think about all of that?
So for me, you know, one of the things the care referendum highlighted was an appetite for real change, not for sort of babying around this. When it comes to tech, there's some really, I see companies all the time, they come to me and say, hey, listen, I've got this thing that's going to rock your world. And sometimes it does. Sometimes it's a bit underbaked. But I say to them, who's going to pay for it? And most of these companies are locked out of the system because there's no funding framework to say, yeah, your idea is great, it's going to save us 1 million care hours, let's deploy it. Instead, they're mired in, you know, I know one company is on its second pilot, it's going to take another 3 years.
Sure.
And you're like, would you ever just get a move on? You know, I know you've got to test things, but at the same time, the technology, if we test it now, in 3 years when we deploy it, it's out of date.
Yep.
So we need to move our cycles along here. Otherwise, I think we're always going to be 5, 10 years behind where we want to be. And we have an opportunity, despite my speech, from a position of strength. Our home care system compares internationally quite well in terms of its fully funding, the amount of people that get it, how easy it is to access.
Yes.
We're in danger of losing the opportunity to reform from strength and instead do it from a position 10 years.
Yeah, and certainly some of those technology solutions, I've meet a lot of those companies and met them on trade missions around the world where they're deploying those solutions and they find that they struggle to I suppose, get traction and implement solutions here in Ireland, and they're off doing it in health systems around the world, and we'll talk about that later in the day. Look, I think we're short on time, so I just thank all of you very much on your behalf, and thanks a million. Well done. Good job. Just before we finish for lunch, we're just going to talk about the Innovation Award. So I'm delighted to announce and introduce this year's Innovation Award in partnership with UPMC. This year's award, we've received a record number of entries from Ireland and abroad. And now we'll watch a 90-second pitch video from each of the companies, and our esteemed judges will pick 3 of the nominees to announce directly after lunch. The 3 finalists will be interviewed by broadcaster Andy O'Donoghue in tomorrow's Innovation Award session to make sure we come back tomorrow with the Innovation Award winner. So the first one is the Menopause Hub, Ireland's first dedicated menopause clinic. The Menopause Hub is a centre of excellence for all things menopause, educating, empathising with the empowering women to navigate menopause at home and at work so that they can continue to live the life they love.
Hi, my name is Loretta Dignam. I'm the founder and the CEO of the Menopause Hub, a global centre of excellence for all things menopause. Founded in December 2018, born out of my own experience of going through menopause, which I found to be lonely, challenging, and difficult to navigate. Since then, we've been revolutionising menopause, which for up to now has been a taboo, neglected topic. We've opened 3 dedicated, evidence-based clinics, and through our digital technology, enhanced the patient experience through telehealth video and our new Menopause Hub app. Women tell us every day that we are changing their lives for the better. And in the workplace, through our groundbreaking Menopause Hub Academy, we offer workplace training, accreditation, and the Menopause Workplace Excellence Awards in partnership with Great Place to Work. 50% of the population will experience menopause, and the other 50% may be impacted by it. And a staggering 80% of women experience symptoms, of which there are over 40. Did you know 10% of menopausal women quit work due to symptoms, and up to 40% consider giving up work? A huge burden for the employer, costing up to $500 million in Ireland and $10 billion in the UK. This is a global issue, and the Menopause Hub is going global.
Yep. The next entry is Shine VR. It's an immersive cognitive behavioural therapy platform delivering data-driven, personalised experiences for enterprise and healthcare customers.
Hi, my name is Neil O'Driscoll and I'm the co-founder with Andrew Jenkinson of vStream and our platform Shine VR.
The team in vStream have been very busy, so are you ready?
Yeah, a bit scared of this next.
Don't be scared at all. Can you see?
Absolutely, I'm looking now. How did that get there? Oh, sacred heart. Oh, sorry, I didn't mean. Oh, that's like outside. Oh my goodness. I'm flying. It's unbelievable. Seriously. Oh.
Do you feel like you're flying, Teresa?
Yeah. I'm off over the mountains. Oh, look. Another of my wishes to fly. Oh no, this is unbelievable. Oh, sacred. Oh, that's beautiful. I'm going way up. I'm looking, look at the mountains. Oh no, I'm in heaven. I'm in heaven, lads. Oh my God, my life is only beginning.
It's beautiful, Teresa.
You're coming back to the real world.
Oh.
Did you forget about pain,
Yeah.
do you think?
Oh, totally. Because I was away somewhere else, you know. I wasn't here.
Visit vStream at the Future Health Summit 2024.
Our third entry is Symantec Medical. Symantec Medical are a Dublin-based medical device company that are developing new generation medical technologies for cancer diagnosis and treatment.
Hi, I'm Stephen Gagan, CEO and co-founder at Symantec Medical, and we're changing how cancer is diagnosed and treated through computer vision. When a patient undergoes a diagnostic procedure, such as a biopsy or a surgery, the success of that procedure isn't determined for a number of days or weeks later. Any unsuccessful or incomplete procedures must generally be repeated, and depending on your cancer and procedure type, this can be up to a quarter of biopsies and up to 35% of surgeries. This leads to serious delays to diagnosis and treatment, elevated risk to patient, drastically increased costs, and significant frustration for healthcare providers. We're developing a novel computer vision-based device for real-time analysis of tissue, which can be used to help determine the success of an ongoing procedure. We use established approaches and methodologies that most clinicians are familiar with. Our device does not come into contact with the patient, and we don't utilize any contrast agents. Our technology also provides a human interpretable audit trail to ensure traceability and quality. Our beachhead application is within lung cancer biopsies. With 2.5 million people diagnosed each year and around half of patients requiring multiple biopsies, the addressable market is close to $4 billion. We will initially target the US market and obtain FDA clearance. Our groundwork for this was completed in the BioInnovate programme. We're now based in UCD on an Enterprise Ireland ComFund, and we've since partnered with the Royal College of Surgeons and the University of Galway. We're now looking to raise a seed round to support further development of pilot studies of our technology. We also have a strong founding team with the required commercial, technical and clinical expertise to execute. If anybody would like to chat further or ask any questions about our work at the summit, please feel free to come up to me. Otherwise, you can reach us via our email here. Thank you.
Our next entry is T-Pro Copilot. Headquartered in Dublin, T-Pro is a global leader in clinical documentation and clinical workforce solutions, introducing their new Copilot today.
Hi, my name is Conrad Bernat, and I'm the head of artificial intelligence at T-Pro. There's a global increase in patients and documentation requirements. On the other hand, the healthcare providers spend over half of their time on paperwork rather than patient care. Documentation burden is linked to medical errors, poor quality of documentation, patient safety risk, staff turnover, and burnout. In T-Pro, we are committed to alleviate this documentation burden by using the state-of-the-art technology. We put together the best speech recognition in the medical domain with the best generative AI to create a truly medical assistant that we call T-Pro Copilot. With T-Pro Copilot, you just have to care about the patient, and the system will take care of taking notes, generating the first version of your clinical notes. Then the clinicians can review and approve these documents just a few seconds after consultation is done. As we are a global company, this technology will be available immediately to hundreds of thousands of users that already use T-Pro as their workflow manager. We are looking forward to be part of the solution of this global problem. Thank you.
Our next entry, Intelia Therapeutics Ltd, is a clinical stage pharmaceutical company which aims to develop a novel, non-antibiotic approach to treat and prevent severe bloodstream infections.
In a world where sepsis claims millions of lives annually, Intelia emerges as a beacon of hope. With nearly 50 million cases and 11 million deaths each year, sepsis represents a global health crisis. But Intelia is poised to revolutionize the landscape with our groundbreaking drug and companion diagnostic. My name is Professor Steve Kerrigan, and I am co-founder and chief scientific officer with Intelia Therapeutics. And we believe that the solution is not more antimicrobials, but a complete paradigm shift towards a new type of drug therapy that works alongside existing treatments. By targeting the dysregulated response to infection, our host-targeted therapy offers the potential for improved outcomes, reduced reliance on antimicrobials, and enhanced resilience against antimicrobial resistance. Led by a world-class team of scientists and entrepreneurs, Intelia stands at the forefront of innovation. Our drug will be the first therapeutic to treat early sepsis, addressing a critical unmet need in the market and establishing a foothold in a segment with no competitors. Positioned at the convergence of two lucrative markets, the sepsis therapeutics sector valued at $6.2 billion, presents a vast opportunity for expansion. Meanwhile, the sepsis diagnostic market, valued at 1.6 billion, offers a complementary avenue for growth. Join us in our mission to revolutionise healthcare and make a meaningful difference in the fight against sepsis. Thank you.
Our next entry, Care Connect. Informed by the limitations of traditional healthcare models, Care Connect's mission is to drive how healthcare is experienced, accessed and delivered to patients across Ireland using the latest digital technologies and integrated across structured processes and workflows.
Having worked in both hospital and community settings, I understand the limitations in our traditional model of healthcare and the growing pressures that are driving the need for us to make change to customs and practices that have existed for decades. Here at Care Connect, our mission is to drive this change, connecting patients and clinical staff on a pathway of digitally integrated clinical care. The digital technologies that we use have transformed how care can be provided, integrating processes and workflows to enable our dedicated nursing team to support every patient remotely wherever they may be. Our clinical interventions are data-led, they are dictated by strict care protocols and are developed by our multidisciplinary team using thorough evidence-based research, clinical guidelines and international best practice. Our integrated care pathways are aligned with the ambitions of Sláintecare, with national and international best practice and strategy for digital health. We are committed to addressing the current and future challenges of healthcare, delivering care that fosters a culture of respect and patient participation and clinical advancement for everyone.
Our next entry is LEP Biomedical. It's a preclinical stage company based in Ireland with a core mission to make glaucoma drainage surgeries 100% successful and relieve the burden associated with poor surgery follow-up care. Do you want to go next one? We'll go on to the next one. InRobotics Social Robotics is a spin-off from the Universidad Carlos III de Madrid, dedicated to digital health integration, cutting-edge technologies such as social robotics and artificial intelligence to develop solutions for the benefit of society.
Imagine that your child, a family member, or a friend suffers an accident resulting in a permanent condition. This is a life-changing situation for anyone. These people require special care and rehabilitation services that are very expensive and sometimes not easily accessible. Inrobix is positioned as a reference company within the digital health sector, integrating high technology such as social robotics and artificial intelligence, helping to improve rehabilitation treatments. We have developed an intelligent software that allows to develop this type of rehabilitation sessions in a completely autonomous way, and, in addition, this robot will be the companion of these patients and will accompany them during these long rehabilitation processes. It helps them to improve their adherence and motivation. Inrobix is the first and only clinically validated rehabilitation solution based on AI and social robotics, with CE marking as a medical device. Our team has strong leadership potential as we combine our expertise in technology and healthcare with a passion for improving people's lives. It is a flexible solution and adaptable to different environments such as clinical, residential, and even home environments. The ultimate goal of Inrobix is to become a reference for the stimulation and accompaniment of patients in their homes, serving as a link between these patients and professionals.
Thanks. Is that complete? We're going to try once more to go back to LEP Biomedical's video. So after this, we're going to break for lunch, and we'd ask people to visit the exhibitors and perhaps go after those prizes. And I think if any of the companies are here, we'd invite them to come up to the stage to have a photograph after this. But obviously, everybody else, you're very welcome to go for your lunch. So.
Hello, my name is Dr. Alan Hibbets, and I'm the CEO and founder of Let Biomedical. It is our mission to transform glaucoma surgeries. Currently, these critical sight-saving surgeries are failing patients and doctors alike at rates of 40% by year 1. This is down to excessive post-operative inflammation and poor patient compliance in post-op drops. We aim to eliminate both of these problems through our proprietary drug-eluting implant, HiaGuard. HiaGuard is inserted in less than 10 seconds as part of a normal surgery, and it elutes out microdoses of anti-inflammatories to better address the problem at source and eliminate the need for any patient eye drops after the surgery. It is biodegradable and not externally visible. Our preclinical testing has found statistically significant improvements in safety and efficacy versus controls, and all our KOL feedback has been almost unanimously positive. We're now looking at clinical trial design in Germany. The glaucoma market is growing at 16% year on year, and we have a €350 million SOM. To achieve this, we have an excellent team covering all our technical necessities, and we're advised by experts in the EU and US who've had prior exits in the space. We are a unique product, and we aim to completely dislodge drops as the standard of care. To conclude, we have an excellent team, an excellent product, and we're addressing a real-world need. Thank you so much for your time. We are Let Biomedical.
Thanks, everybody. So we'll break for lunch. There's some fantastic videos there, and it'll be interesting to see who the shortlist is. So we'll see you all back at 2:30, I think 2:20. Yep.